Welcome to Medicine Redefined, a podcast focusing on helping you reclaim ownership of your health. I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja. We're your hosts, here to challenge conventional practices and uncover the stories behind pioneers shaping the future of medicine. Our conversations not only focus on the individual level to dissect common practices for health optimization, but also zoom out to enhance systemic change.
Join us as we look to break the status quo, move the needle forward, and put the health back in healthcare.
Welcome back to part 2 with Dr. Shawn Arent. Here we pick up our deep dive into hormone physiology for performance enhancement. In part 1, we covered cortisol, insulin, growth hormone, and briefly touched on the sex hormones. Today we'll dive into the second part of the gonadal or sex hormones from a female lens. We'll also discuss female physiology and the menstrual cycle, why programming around cycle phases isn't supported by science, and what actually matters for female athletes. Thyroid hormone optimization, and the critical role of reverse T3 that most panels miss, and why thyroid affects everything from recovery to cholesterol. We talk about catecholamines and the autonomic balance, understanding sympathetic versus parasympathetic dominance and practical strategies for optimization, and then a topic that I've been very interested in, and that's GLP-1 agonists and muscle preservation. These drugs are revolutionary when it comes to weight loss, but muscle wasting is something that we need to be concerned about. So thankfully, there are lots of people out there working on different pharmacological enhancements to help with muscle regain and preserving as much muscle as possible. Especially myostatin inhibitors are something that I was very interested in. So we talk about that, as well as the future of performance enhancement, as some people like to call them non-androgenic anabolic drugs, and what's coming next. As a reminder, Dr. Shawn Arent is the leader in the world of human performance and sports science. He is a professor and the chair of the Department of Exercise Science in the Arnold School of Public Health at the University of South Carolina. He also directs the USC Sports Science Lab. Let's jump right back in. All right, Shawn, let's pick right back up where we left off. So we had just talked a lot about the male hormones, testosterone, emphasizing on that. Mm-hmm. I'd like to shift gears and talk a little bit about from the female physiology.
Sure.
I think it might be worthwhile, if you're interested, in talking a little bit about the menstrual cycle and what stage of that, whether in the follicular phase or the luteal phase, and how that might affect it. I know there's been a lot of discussion on social media, particularly in a couple of recent papers that have actually come out, which you might be familiar with respect to the stages of menstruation and the menstrual phase, and whether or not that affects training, whether it should affect training, performance, etc. So what can you tell us about that, and take it whichever way you want?
Yeah, I think I could probably sum that up fairly quickly in that the evidence doesn't support there's much of an effect. It's very individual, right? So within given phases of the cycle, whether you're talking early follicular to late follicular, where you're talking about the changes in estrogen going from its lowest levels to its higher levels and then peaking at ovulation, and then obviously maintaining high during mid-luteal before falling during late luteal as they move towards the actual bleed phase, as we're looking at that menstrual week. The reality is, it's much ado about nothing, to be fair. There's a lot of social media hype around timing this around phases of your menstrual cycle. Training should change, diet should change. The reality is the science doesn't support that. What is supported is the same thing we support for males, which is autoregulation. When you're feeling a certain way, and so not everybody's going to have the same signs and symptoms during phases of the menstrual cycle. So a lot of it is modifying your training, your diet, based on how you're feeling, not specifically because of a phase. And I think the part that worries me a little bit is if you look at a lot of the recommendations, especially I work with athletes, right? And the reality is I look at some of the things that are out there and all I can ever think is, when in the hell would you ever train hard? There's over this 4-week phase, there's 2 weeks where they don't have them doing a whole lot from the standpoint of progression, just because they think something's timed around the cycle. So I think that's really problematic. And I think really what you're better off going off of is how they feel. The other thing too is, again, being in that athletic world, you don't get to pick the timing of your competitions around your menstrual cycle, right? So these women are under pressure to perform regardless of what that phase is. And I think if nothing else around sort of feelings during sort of premenstrual phase, menstrual phase, it's more along the lines of helping to manage those symptoms and some of the things that might go along with that. But overall, when we look at effects on reaction time, adaptation, capacity for hypertrophy, strength changes, if any of that exists, honestly, it's so small And I think what gets lost in this is if you were to compare the influence the phases have versus the influence of training and competition. Training and competition, man, those are the big rocks. Those are the big movers. That's going to dictate more of the physiological response than just those menstrual cycle phases. So is it something that needs more research? Yes, and it's actually a lot that we have ongoing. We just wrapped up a study with our beach volleyball team looking at this in their off season. There was a minor effect of cycle, but again, they weren't in competition. And the effect was so small from a strength standpoint versus power that I would expect that probably gets pretty washed out during the competitive phase. We've been part of an international consortium that's been doing a study looking at this. Hopefully those results will be coming out later this year as they compile all the sites across all the countries. But again, nothing of particular note. And this isn't to say that hormonal fluctuations and female hormones don't matter. That's not the point at all. It's how much do their normal phase fluctuations really influence performance? And the reality is very little, if any, for most individuals.
So most people will learn 28 days is the average cycle, plus
Sure.
or minus 7, right? So
Yeah.
to your point, I think if you're going anywhere from 3 to 5 weeks and you're only doing consistent training, we know that consistency trumps all. But I think maybe for those just not familiar, if you're starting with the menstrual phase or you're actually the bleeding phase, like you talked about, after that is, oh my God, this is going to be terrible. It's the follicular phase next.
Yeah. So you go from early to late follicular and then into the ovulatory phase.
And then so that'll be luteal and stuff. And so what are the predominant hormones during the early and late follicular phase?
So in the early follicular phase is when estrogen and progesterone are both at their lowest. Late follicular, estrogen rises, progesterone still low. As you move into ovulation, that's when you get peak estrogen and progesterone starts to climb. So it's rising at that point. It's really during the mid-luteal where they're both at their highest. They're both high, right?
Yeah.
Because obviously you hit peak estrogen during ovulation, but it's still remaining fairly high during mid-luteal. And then during late luteal, that's when you get both of them starting to fall back again. And this is where you get that menstrual precipitation in terms of what you get from there.
I know that at least when we were Rutgers, you worked a ton with because the soccer team was at a national elite level, right? And so I know that at some point in the sports medicine realm, we would talk about, okay, why are ACL injuries particularly higher in the female athletes, right? So we talk about the hip to pelvic ratio, or pelvic to knee ratio, valgus collapse, that kind of stuff. We also talked about, or at least one of the theories is the hormones have a lot to do with it, right? So we know that progesterone and estrogen can contribute to some ligamentous laxity. I guess my question for you would be, you talked a little bit about autoregulation. What does that exactly mean from a training injury prevention standpoint? What does that mean?
So let's back up a little bit to lead into that. That'll help us. Okay, so if we're looking at this from the hormonal influence potentially on injury, I would actually say that the absence of these hormones because of dietary insufficiency and overtraining are going to be even worse than just the natural fluctuations of these hormones when it comes to injury. The other thing too is recognizing that even if, for example, with estrogen at its peak, whether it contributes to some degree of joint laxity, the question then becomes how much of that can really be mitigated though by good power and strength development? Because you know that women, when you equate across as many things as possible, the one area where women consistently show up lower than men is in power, right? And a lot of that has to do with testosterone's effects on muscular contraction and the receptors that contribute to this. So there's a real opportunity there for female athletes from a power development standpoint. And that also from the ability to handle rapid movements and rapid readjustments. That's the definition of power, right? It's that ability to rapidly respond in that situation. So I think, and I think maybe the simplest thing I could do to paint a picture that you mentioned when we were at Rutgers, we worked so closely with women's soccer and what an amazing group they are. We were very fortunate to have a coaching staff that was bought in, that wanted the best for their players. But the short part of this story is when we first started working with them, they had 5 times the national average for ACL injuries, right? Over the last 6 years that we worked with that team, they had 1 season-ending injury. 1. And when you look at that, we didn't program anything around the menstrual cycle or hormones. We measured it. We measured hormones. We were looking at biomarkers. We were looking at the system though. So it was a real dedication to strength training on their end. They were amazing about that. It was systematic periodization throughout the training phases across the entire year. It was nutritional intervention to manage all these things. So we were using all these other factors to get at any influence these hormones might have in the first place. But we were looking well beyond just estrogen and progesterone. And we're looking at growth hormone. We're looking at inflammation. We're looking at dietary status. We're looking at recovery metrics. So I think at the end of the day, it sounds really appealing from a programmatic standpoint and from a sales standpoint to suggest that women need this magic intervention around their cycle phases to be good athletes. And the reality is, to put it really simply, and I know Kirsty Elliott-Sale over in the UK has done great work in this area, but as she notes, records have been set in every phase of the menstrual cycle. That's the reality, is women perform. And so I think in some ways we do a bit of a disservice if we suggest that phase might be influencing that. But I do think that what we can get out, though, is some of the factors that can disrupt those hormones and maybe make them more important. If we attend to those things, for example, dietary intake, training and recovery, right? What sleep, when we start addressing all those things, those make for a much more resilient and responsive typical cycle that allows them to function at an optimal level. That would be your key to injury prevention more than anything else. More so than just paying attention to, hey, oh my God, I'm ovulating this week, I'm going to blow out my ACL. That's just, it's not the way it works. Should we maybe pay particular attention in certain phases? Sure, but here's the problem. That's assuming that we can measure accurately enough to know exactly where they're at. As an example, across most teams, the gold standard in this case would be blood-based markers, right? We would track the entire phase because, as you noted, that duration of phase varies from person to person. So we can't just assume, but we know it's roughly 28 days, right? So it gives us a benchmark. So there's been criticisms of some of the tracking apps, but then who really has the resources and the dedication to monitor every few days, every week, to know what phase they're in? And would we get those results early enough to know what we need to predict to do over the next few days? I would argue the burden of that is more invasive than damn near anything else we could do that would just be common sense from a training and competition and feeding standpoint. So I think there's some lessons in there in terms of what we should be doing. And I guess it's one of those things that just because we can doesn't mean we should. And so it's, can we assess all these things? Can we plan for them? Yeah. Should we? I don't know. Some of it's pretty burdensome. And you might have the elite of the elite teams having the capacity to do that. Maybe it makes them feel like they're being proactive about it, and that's great. I would also argue, though, too, that there's some value in that proactive concept of just monitoring because you're paying attention. So are you really basing this around the phase of the menstrual cycle, or are you paying attention to monitoring in a way that clues you into other things that may be going on? So that's where your intervention comes in. And so I think that, yeah, some of it's just common sense. You're right. A lot of it sounds great, though. It's super cool to think, yeah, man, we could program around this. But like I said, they don't get to choose when they compete. So your best are your best, no matter where you put them. And so coming back to your question about the autoregulation, what does that look like? The reality is then is throughout the menstrual cycle, I think one of the things that can be very useful is to really track how an athlete feels during those phases of the menstrual cycle. And if you start to detect patterns, and they typically have, like we've worked with a few athletes that certainly during that sort of menstruation week, during that bleed phase, and maybe the days leading up to it, whether it was severe cramping, whether it was just discomfort, they didn't sleep as well, whatever, like those are symptoms that we can pay attention to and help them through their training and recovery. It's a side effect to the phase. It's not because of the phase. Does that make sense? So that's the approach that we've traditionally taken that I think works really well. That being said, this is not to suggest that we don't need more information in this area. And we're continuing to work in this space. One of my great colleagues here, Katie Hirsch, is doing some awesome work around female athletes. And then again, the work that Kirsty Elliott-Sale and others around the world are doing. I think we're adding information to this part of the puzzle, but most of the information that we have right now would suggest that modifying training and stuff just based on menstrual cycle phase adaptation is not really warranted at this point. Basing it around how they're feeling and symptoms that may go with it, that's a different story, but that's not quite the same thing.
Yeah, I think it's a classic majoring in the minors type situation. And to your point, I don't think part of the check-in process at the Olympics is to register what phase you're in, right? Let's talk about progesterone. So we talked about,
Sure.
So you said progesterone, estrogen lower as we get up towards the luteal and ovulatory phase, both of them are going to rise. I should also mention you have that LH peak which causes the ovulation that happen. Now, we talked earlier about how testosterone is still on an absolute level, still probably the highest level, or in terms of all hormones, even in females, right? Is that correct?
Mm-hmm.
And the importance of that both in males and females. However, progesterone is unique to females. Okay, so talk a little bit about the role of that and how that plays in terms of female physiology and why it's not necessarily necessary in male physiology in there and some of the differences there.
The reality is, from a progesterone standpoint, I just probably, and this is a way oversimplification, but for the purposes of this, it works. But so estrogen can be very supportive to athletic performance and health and things like that. Progesterone, on its primary rise, is far less favorable to performance, right? So one of the things that happens with increasing progesterone can be challenges to thermoregulation, because it can help increase core temperature. There may, in certain situations with the central nervous system, there's some evidence for it's a little bit of an overstatement, but a bit of a sedative effect, where in other words, it may dampen that CNS response just a little bit, which is why there's been some suggestions that maybe when progesterone's at its highest, that maybe reaction time's not as good. Again, it depends on the athlete, depends on the situation. It may play a role in some of the psychological responses in terms of mood, feelings of fatigue, and things like that. And it looks like, whereas estrogen seems to be fairly supportive of anabolism, or at least protein synthesis to some degree, progesterone can play a little bit more of a role in protein catabolism. And this does not mean you want to block progesterone, right? So in other words, like, these play complementary roles under a normal cycle phase, a normal female physiology. So there's the nature of what they both lend to this, but you also notice that over most of the menstrual cycle, comparatively speaking, progesterone does not peak for as long and is not as high nearly as long as what estrogen is. And so that's where we pay attention to what that impact might be. But yeah, it's all part of the normal physiological functioning more than anything else.
Yeah, and I think an important thing to mention it from a fertility standpoint and from a childbearing standpoint, that's the most important thing, right? And so that's
absolutely,
I think,
that's
even things to talk about. That being said, though, believe it or not, at least in the physique competitor, and you'd be able to speak to this, right? Because if your wife, if somebody's necessarily not interested in that, they were like, okay, what role does that serve? Turns out, actually, to your point, serves a very important role in mood regulation. We talked about the role of estrogen in males in terms of mood regulation. In fact, people will be to know that the rapid drop in estrogen is oftentimes responsible for the PMS type of symptoms that people have. And so one of the treatments, just micronized progesterone, it could be for that. And so why that tends to happen in some individuals more so than others, I don't think we know the answer to that. But it is very important. So I think, it's to your point, like this context and taking a big picture approach to looking at this. And again, left the audience last time with me looking at androstenedione down and going up and taking egg yolks, and physiology isn't quite as simple, to your point.
Right.
I realized I took something for granted. I'm taking the audience for granted in terms of been talking about these hormones at a primary level. So I know we've hinted at that. You've hinted at that a couple of times. So we've got the hypothalamus, pituitary, adrenal axis, hypothalamus, pituitary, gonadal axis. Yep. I'll just give a little primer for them because maybe we haven't just been very clear with this. So we talked a lot about cortisol at the hypothalamus. So we have corticotropin releasing hormone, CRH.
Correct.
The pituitary, ACTH, adrenocorticotropin hormone, and then down to the adrenal cortex, cortisol. For growth hormone, we have GHRH, growth hormone releasing hormone, or somatostatin. It's another name.
Yep.
And then we have, what's the next one we have growth hormone at the
growth hormone.
And then down the road, you're going to have IGF. Testosterone, you're going to have gonadotropin releasing hormone, FSH, LH, which we're talking about. And then at the gonads, you're going to have that. Insulin is the exception. We talked a little bit about insulin. Yeah. That's not going to be in that axis. That's going to be in the pancreatic
level between that and glucagon. Correct.
Yeah, that and beta cells. Okay. So with that clarified, let's continue. So we talked a lot about that. Last time we touched about the importance of some of the other ones that are not often talked about in social media as much, although the prevalence of thyroid hormone abnormalities is extremely high, especially in that hypothyroidism, far more common than hyper. So let's talk about hypothyroidism. You even talked about how oftentimes people, when you're looking at your labs, RT3, you said was really important. So give us a high level of thyroid, right? I forget so again, TSH at the pituitary, I forget what's preceding that. TRA?
Yeah. So you've got thyroid stimulating hormone, correct. Mm-hmm. And then when you move from thyroid stimulating hormone at that level down to the thyroid itself, now we're looking at the thyroid production. So we're looking at primarily T4 and T3, right? So T4, or thyroxine, is the predominant form of thyroid hormone in the body. About 90% of what we manufacture is primarily T4. And then other tissues can convert T4 to its active form, which is T3, which is triiodothyronine. So thyroxine is comprised of 4 iodine molecules. Triiodothyronine is 3. Okay. Now, reverse T3 is basically an inactive form of T3. So same 3 iodine molecules, except they're configured differently. And the problem is they actively compete for T3 receptors. And so what reverse T3 will do, because it's not the active form of that 3 iodine molecule, is it can really blunt metabolic response in that case. And so what we can get is, in some cases, let's say, for example, if somebody's taking T4 primarily for the treatment of hypothyroidism, but if they get to a point where they don't necessarily need that T4, or if the T4 dose is potentially wrong, you can get T4 conversion to reverse T3 instead of active T3. The other thing too is, under situations of high metabolic stress, for example, overtraining, high load, insufficient caloric intake, the body's natural response is to try to slow down the metabolism so that we retain muscle, fat, things like that. And so we can get conversion to reverse T3 in that case as well. I don't think it's looked at often enough. It is not typically a part of most thyroid panels. You have to ask for it. And I think in some ways, because of that, we often miss part of the story. The other thing that's really interesting too is, so the way I've always looked at thyroid hormone is thyroid's a permissive hormone. It helps other hormones do their job better, right? So because of what they do to cellular metabolism. The interesting thing is, in a lot of cases, and we've seen this now in a few of our studies where we're at our highest training loads, or where you're looking at insufficient dietary intake. So for example, we've seen this in ballet dancers. We've seen this in soccer players, field hockey players during their highest training load phases. In many cases, we'll see LDLs actually go up. And we're looking at, why are low density lipoproteins? They're not eating that much more fat. Like, what's going on? And usually it's because T3 is falling, right? And so what's happening is T3 can actually help with the metabolism of lipids. And so in many cases, you'll see cholesterol go up, you'll see LDL go up because thyroid hormone is going down. Right. And so and again, we've seen this across multiple studies, as have others. This isn't some, oh my God, Shawn found the coolest thing. No, we're just consistently seeing what some others have as well from a metabolism standpoint.
Does HDL go up too in that case then?
No, not really. As a matter of fact, in some cases, you'll see it go down because of preferential conversion to LDL in those cases. And that's one of the challenges.
Interesting. Walk me through in terms of labs. So let's just take that person, the ballet dancer, caloric deficit, high metabolic stress, high demand. You're going to get that panel. Are you going to see elevated RT3?
Yeah, we typically do in the studies where we've examined it. We haven't done it in all of our studies. It depends on what we were doing and what we were asking. And sometimes thyroid was not a primary outcome for us. It was a secondary consideration. But typically in the situations where we have seen that, we'll also see elevated cortisol, typically elevated catecholamines at rest as well. So it's really during those high training load phases that we'll see it. And again, I think one of the reasons why, when it comes to sort of biomarker tracking, modeling, it's why I like a bit more of a comprehensive approach rather than just trying to single out one or two things, because there is individual variability. And as you hit on before, looking at dealing with some of the basics and the primary hormones and stuff, and then getting at the axes, the reality is, I think one of the things that attracted me to endocrinology, the reason I studied it, was both the complexity of it, but also the incredible redundance of it, right? We have built-in stopgaps. For example, you look at cortisol, and obviously we know that CRH, or corticotropic releasing hormone, you also see it as corticotropic releasing factor, CRF, is a primary stimulus for it, but not necessarily during exercise. During exercise, actually vasopressin, especially arginine vasopressin, is a primary stimulus for ACTH and cortisol secretion. There's multiple ways to get at that same outcome in order to do this. And because of the complexity and importance of feedback and feed-forward regulation, I think that's where you get some of this. And I think that's where one of the things that we'll often see, so if you're looking at that thyroid panel, a very important part to look at is what the changes are in TSH. Right? Because what's going to happen is, if the thyroid hormones are not able to do their job, in other words, there's so much stress on the system, or there is a problem with that T3 conversion, so metabolically there's a challenge, the feedback mechanism is going to tell TSH to increase, because TSH is basically going to look at this. Your hypothalamus goes, hey, crap, like, we're not producing enough of this. I got to get more. We're not getting the desired effect. So what happens is TSH goes up. And so under those situations of metabolic stress and things like that's certainly a situation where looking at these sort of increasing responses to TSH, T3 may not follow along with that because it is not being converted at a fast enough rate or it's not doing its job. And so that's where that feedback response becomes really important too.
Are there any instances where T4 or any of the thyroid hormones might be elevated? And I'm not talking about RT3, so T4 particularly, with respect to training and performance and that kind of stuff.
Yeah, it's actually cool. So training has a really interesting effect on thyroid hormone. So it does appear that chronic training can actually increase resting levels of T4. We think it's mostly due to an increase in thyroid turnover in terms of what we're getting, but it's cool because it seems to be a unique effect to exercise where under a non-exercise condition, if you saw that going on, then there's a concern over clinically what that might mean for thyroid function. Exercise seems to be unique in this. So with that increased thyroid turnover, it doesn't seem to be of clinical importance. It is simply a natural response to the increased metabolic demand of exercise. And so the thyroid responds that way. So yes, you can actually see in some cases T4 go up a little bit. We typically see more of a rise in that than T3, again, mainly because it's a thyroid sink, right? That's where we're storing most of this in terms of to then convert it to the active T3. But yes, there are some situations with training where you can see that rise. We've seen that a few times. It doesn't tend to be a large rise, maybe 5 or 10% at most, if you're even seeing that, but enough that it's notable. But again, it doesn't appear to be of real clinical significance in that case.
That's around the workout though, right? Around the training session?
Yes.
Okay. So
yeah,
not like
primarily. Even during rest though, even with a chronic training program, we can actually see this increased thyroid turnover. So you may, when testing, have a slightly elevated T4, but the thing is, it appears to stay within clinical range. So it's not an abnormal response. So we don't really hang our hat on that. But that being said, when you start looking at those changes over time, especially if you're coupling that to changes in TSH and T3 or the reverse T3, it's enough then that may spark some interest on our end to consider what the context is driving that and looking at dietary influences, sleep influences, training influences, stress influences, things like that.
Yeah, I'm just thinking about, I'm trying to apply everything to this from a clinical performance point, right? So yeah, we talked a little bit about in overtraining states, how heart rate can be elevated. Obviously, that's a very straightforward thing with respect to elevated thyroid levels, your heart rate is going to be elevated. And how do you, I guess it doesn't matter if you are going to take a big step back and look at their diet and nutrition because you're going to affect, you're not necessarily trying to manipulate individual hormones.
Correct.
But I suppose my question for you is, are there instances where you've worked with clinicians where it does warrant manipulating individual hormones in those circumstances? Maybe because, I don't know, during a certain macro cycle for an athlete or like extended thing, or actually combat athletes, right? And I'm not even thinking, I'm military, right?
Yep.
You don't get like a one event thing. Maybe you're there for months or years. How do you play with that?
I think it depends on what the hormone is that you're trying to modify and what the change in that hormone represents to you. So for example, at the simplest level, testosterone, right? If we see testosterone fall, especially to hypogonadal levels, intervention with testosterone can make tremendous sense if you don't have the capability to back off on other factors, right? So let's say, for example, let's use like ranger training, right? Like ranger school, and they're getting beat up during that period of time. They are in a massive caloric deficit. They're in a massive sleep deficit. Testosterone falls to damn near zero in some cases, right? So you can't just sit in the middle of that and be like, yo, time out. Let's take a break for a while. We'll come back to this. Let's let testosterone.
Let me do my breathing.
No. Yeah. So there's going to be a situation there. You'll see it, especially with like female physique competitors, when you're looking at that massive restriction that they're into, especially closer to competition as they're nearing these very low body fat levels and stuff like that. The disruption of estrogen, of progesterone, of LH, of FSH, all of those things become very apparent. Thyroid hormone gets interesting because just trying to, say, manipulate that in the short term may not be warranted if really what's needed is a fix in the training or the other demands. On the other hand, if somebody is truly hypothyroid, in other words, there is a dysfunction of the thyroid gland, then continued use of thyroid in whatever ratio of T4 to T3 is probably necessary is going to be something that might be in that case, it would be medically indicated in terms of what we're looking at. But within just a training phase, some of those shifts tend to be fairly acute, but I will say where we've probably had the most impact using biomarkers during these training phases during competition is assessing them in a way where action can be taken in time to actually impact outcomes. And in that case, it's not so much what we do to say, give a hormone. It's really looking at why is that hormone potentially changing and the surrounding biomarkers, and what would that intervention look like to get it back on track, right? Maybe there is more rest and recovery needed mid-season when we're seeing these things carried over from preseason. Maybe this is where I love having dietary markers as well. When we look at iron, when we look at magnesium, when we look at omega-3 and omega-3/6 and omega index, you start to look at those things and it's like, okay, if we're seeing deficiencies here, this gives us some objective ways to consider how we might intervene to adapt to this. And now when we start layering on things like HRV and we start layering on things like sleep and sort of sleep assessment and stuff like that, it gives you a much better picture of what's happening to the whole system rather than just this one small little part. That being said, certainly hypogonadism may be needed to be treated with drugs. If we look at menstrual dysfunction, getting at the root cause of that, there may be other issues besides just not enough calories or too much training. There could be medical considerations there. Same thing with thyroid hormone for sure in that case. If we're seeing a situation where we have this incredibly high hemoglobin or hematocrit, what are we looking at there that the body may be doing? Or if we're looking at incredibly low levels of ferritin and iron, what's happening from a conversion standpoint? Is there actually a disorder there, not just dietary related? So I think that's where somebody on your end, from the clinician standpoint, and this is where I think it's really valuable to me as a sports scientist to work with physicians that actually have an appreciation of performance and optimization, not just sufficiency. Because in certain situations, you'd be like, oh, it's still within the normal range, but you're like, yeah, that's a massive change. Can we do something now before it takes a real turn for the worse? And just because now it's below clinical norm, now we do something, but never mind the 50% drop we saw before. So I think that's where the management aspect and really good communication between the sports medicine and sports science, strength and conditioning, nutrition, and coaching staffs when you're working with athletes becomes so critical. I also think it's one of the reasons why a lot of people in the fitness industry, for example, need to be very aware of what their lane is and what they can realistically interpret. And I think I'm seeing a little, it bothers me. And I know you and I have talked about this before. I think we talked about it last time, actually. It worries me how much people are trying to simplify this conversation, right? In terms of, oh, you got your blood work back. I know what that means. And do you though? Do you really understand how these things interact and what they represent? And this is also, even from a sports scientist standpoint, it's very important for me to have context. Just somebody sending me their blood work and goes, what do I do? I don't know. What are you currently doing? What has changed for you? What hasn't changed? Like, where do you intervene if you don't know what's going on in the first place? Because then it's easy to just slap a fix on there and be like, oh, your iron's low. Let's give you an iron supplement. Yeah, but why is your iron low? What's going on from the rest of what you're doing to make that difference? Why is HRV changing? Is it falling? Why is sleep not? What's going on that's doing this? We get at everything from external stressors to some of the internal stressors from the training itself, dietary impacts, sleep impacts. And so I think when you see how all these hormones and really biochemical influences, when we look at, say, inflammation, right? Not necessarily a hormone when you look at cytokines, but they are biochemical indicators of what's going on in the system. I think that's when putting the pieces together becomes so important and not so simple.
Love it. Awesome. Let's shift to talking about epi, norepi, or adrenaline,
Sure.
noradrenaline, right? So this acute and chronic catecholamine response to training.
Yeah.
What is it at a high level that we need to understand? Maybe define people for what catecholamines even are, those who are not familiar, and how does training and performing and affect that?
So you really have three primary catecholamines and two in particular that we often see in greater abundance, right? So you've got epinephrine, norepinephrine, which if you're from Europe is adrenaline, noradrenaline, and then dopamine. So those seem to be those are the big three, if you will, with epi and norepi providing a lot of what we see from a fuel mobilization standpoint. So catecholamines by default are considered catabolic. They break down, right? But they do this amazingly well. There's a purpose to that because for those that don't fully appreciate their role, think of them as a huge part of the fight or flight response, right? Because this is where what catecholamines, along with cortisol, what their job is to do is to mobilize resources. Whether you're staying to fight or you're running your ass off, the bottom line is they're there for a reason to help your system respond. So let's put it in an exercise context. At lower to moderate intensities, we don't tend to see a large shift in the catecholamines. You'll see some go up. Catecholamines, especially epinephrine, are primarily derived from the adrenal medulla. I was jumping ahead to cortisol. Cortisol is derived from the adrenal cortex, all right? So both of these sets of hormones as part of the fight or flight response come from the adrenal gland. Now, at the adrenal medullary level, in abundance, we'll also get norepinephrine too, but norepinephrine is also produced by sympathetic nerve endings, right? Because norepinephrine is a pretty potent neurotransmitter as well. So we can get norepinephrine from the sympathetic nervous system and the sympathetic nerve fibers, as well as from the adrenal medulla. Norepinephrine can convert to epinephrine, have a greater role in terms of its activity, and both of these together help regulate that response. Now, during exercise, especially high intensity exercise, that catecholamine response is really important for mobilizing glucose in particular. They also play a role in lipogenesis too, so lipid mobilization from a fat standpoint. Cortisol complements this quite well. Cortisol is a little more long-acting as a steroid hormone versus these peptide hormones as epi and norepi. The other thing that we see though is really cool. So with training, right? So we take somebody through a 1-year training phase. What you'll see is at the same absolute intensity. So let's say, for example, you were running 6 miles an hour before, we train you for a year, now you do 6 miles an hour still, right? Your catecholamine response will be lower. Why? Because on a relative basis, it's easier. So what we typically see with training is that catecholamines respond very similarly to relative intensity, the percentage of your maximum, your effort, but they dampen in response to absolute intensity, just the total workload, right? Because you're more fit. The stress isn't as great. Growth hormone does the same thing, by the way. But what's interesting is, and I think this is the part that's so funny, so I'm about to hit on what actually made me totally know that exercise endocrinology was my jam. This is what I wanted to do. I think what is really cool is that with high intensity exercise in particular, even after training, we can often see an elevated catecholamine response and cortisol response. And this is often what we refer to as the sports adrenal. And what it is, the system figuring out how to maximally mobilize all resources to handle this big ass stimulus because you're capable of doing it now. But what's super cool about it is that with training, you clear that faster too. So you can jack up that response, but then it comes down much quicker after. So you get the body back into homeostasis a little bit quicker. And that's a really cool hallmark of training, especially for high intensity work. And so when we look at how these hormones interact with each other, that's really where these catecholamines fit in. And what happens is, much like cortisol, that acute response is critical. If we can't mobilize those hormones, performance is going to go down the toilet. Like, we don't have the ability then to mobilize the fuels that we need. And they have an important role in the autonomic nervous system, right? Because they're playing that role on the sympathetic side to drive the system up to respond from a CNS standpoint as well. But one of the things we have to worry about, though, is if they say chronically elevated. So, for example, under situations of continued stress, right? And that's the thing, is that we've mentioned this before. The human body, we don't really care whether it's physical or psychological stress. Stress is stress. Right now, we have a little bit more abundant epinephrine response to physical stress than psychological, but it doesn't mean it doesn't exist. And so what happens is, when you start to look at continued elevations in cortisol, continued elevations in epi and norepi, a lot of these things can actually contribute to some of the cardiovascular dynamics that are less desirable with that chronic stress, contribute to inflammatory cascades and what we're looking at. And then there's a feedback between those two as well in order to continue that response. And so I think overall, the complexity of it's really important. But again, I see a lot of these dampened epinephrine and norepinephrine, like they're bad, and cortisol's bad. It's, no, man, it depends on context. Acutely, they are so important. Chronically, we want to bring them back under control. And that's where stress management, sleep, recovery, all of these things start to play a pretty important role.
In chronic elevations, because again, they clear out so fast, even
They do.
elevated,
They should. They should. That's the problem. But yeah.
I'm sure you've come across instances. Do you check them? You'll check epi, norepi, and just
Yep.
blood markers is the best way.
We'll do blood or urine. So actually morning urine is a pretty good way to track what resting catecholamine levels are as well, because of the consistency of what that should look like. And so we will see some chronic elevations. I would probably say over most of the work we've done, cortisol is a little bit more telling in that part of the story from a stress response. But catecholamines are no joke, especially when it comes to blood pressure regulation, right? Catecholamines are pretty important in that baroreceptor response and how they help regulate overall hemodynamics. And so they're worth paying attention to. The other thing too is people should realize is caffeine intake will increase catecholamines as well as cortisol in most cases. It's just that it's a fairly normal response. And with chronic intake, we actually get pretty resilient to that. It's not as noticeable, but there are some genetic influences there in terms of what we'll see in terms of response to caffeine. And this is why if somebody has some level of, depending on the type of cardiovascular dysfunction, if it's a blood pressure issue, whatever, caffeine intake may need to be very limited in order to not precipitate that any more than it already is.
Yeah. So you touched on something in terms of sympathetic dominance, and it brings me to this concept of, I think, profiles of individuals, right? Sympathetic versus a parasympathetic profile, and autonomic dominance. I would classify myself as a very sympathetically dominant person. I suspect, I don't know, actually, you seem like a pretty laid back guy. I know you like to surf.
No, I'm pretty, I'm way too much sympathetic half the time.
If you were to counsel somebody or get your assessment, and I guess what would your assessment process be like when you're trying to tease that out, and what implications would that have with respect to training and programming and just considering allostatic load in general?
So I think the important thing to realize is that dominance can change, right? So you may have a trait in terms of how you tend to respond to certain situations, right? From an anger standpoint, from an escalation standpoint versus de-escalation, things like that. And I will tell you from experience that has changed for me over the years, right? And so it's one of those things, it's getting a handle on what the psychological input is there. So I think what's important to recognize is when we start to talk about sort of these profiles, are you more sympathetically dominant? Are you more parasympathetically dominant? We've got to consider the cause and effect side of that. And what's the chicken and what's the egg, right? In terms of what order this goes in, because we know that with endurance training, with quality sleep, with things that we can do to reduce inflammation in terms of recovery and how we treat our system, you can become more parasympathetically dominant, right? On the other hand, with sympathetic responses, there may be periods of time where that sympathetic dominance may be very appropriate under situations of high stress where you need to mobilize resources. But over time, if it becomes your main carry forward, this is typically where we're looking at other strains on the system. And ultimately, what we're trying to do is build some balance between those things, right? Because if you're an athlete, if you're an avid exerciser and things like that, you need to be able to mobilize your sympathetic response, but then you want your parasympathetic to kick in when it's time to rest and recover, right? And so I think we look at some of these things, and it's really interesting because it's not even so cut and dry in terms of what's better all the time. Because, for example, we could say, hey, with regular endurance training, we tend to see more parasympathetic dominance here, or at least more parasympathetic contribution. With a high quality diet, protein intake, sufficient calories to support recovery, things like that, parasympathetic nervous system can do its job. But we also see in certain situations of overtraining, we can see parasympathetic overtraining, where what that leads to is feelings of fatigue, malaise, lack of an ability to train, actually a dampened overall response. That's not a good thing. So is parasympathetic dominance always a good thing? The answer is no. Again, it depends on what's driving that. But from a rest and recovery standpoint, we would like the flexibility to shift between the parasympathetic, sympathetic balance fairly readily in order to do this. And so I think it really depends on what we're looking at there in terms of what's going to be driving that. But certainly if you have somebody, okay, let's say, for example, if we work with an athlete that we know does not have problems sympathetically mobilizing, right? Like they're ready to go. We may approach them a little bit differently from caffeine intake. Maybe the dose is not as high, right? Because of what it might do to push that over the edge. So we're aware of that, but that also applies to knowing your athletes and knowing how they respond prior to games, right? Do they get just super amped up, or are they able to keep it in check? And that becomes important as well. And so when we start to look at some of those things, I think that's how we can look at it. But certainly It's not unusual to see heightened sympathetic activity during periods of your highest training loads and intensities, during peak competitions, chronic stress and anxiety, things like that. And certainly if you're not sufficiently replenishing when it comes to nutrients, those are all going to be things that are going to tip it in that direction. So we might see elevated resting heart rate. We might see fairly poor heart rate variability. And again, on a day-to-day basis, and I know we've said this before, but just to reemphasize here, because I think it's important, for those that use wearables that are tracking HRV and stuff like that, honestly, don't get caught up in the day-to-day stuff. Look at trends. Because day-to-day, if you try to base your training around it and things like that, you might have a day where your HRV looks really low. You might feel great. Don't look and go, I shouldn't feel great though because my HRV is in the toilet. It happens. Watch for trends over time. And that's where ultimately you can get your greatest interventions, if nothing else, where the day-to-day fluctuations can be useful. And this also applies to just simply how you're feeling, is pay attention to what your behaviors and your activities were on those days, or it was really good or really bad, what set it into that stratosphere. It's funny, a friend of mine who works with a very high-level rugby team. So alcohol is part of the rugby culture for the most part, but where they've had some real success in helping these guys actually recover better is by using wearables and allowing them to see what it did to sleep quality as well as HRV and some other metrics. It gave them their own data, and the players on their own then started to realize that this was negatively impacting their recovery, so they backed off on it quite a bit. So it's not just telling them why they should, but being able to show them why they should. And then they could look at trends over time with that. So again, there's good application for that.
Yeah, I think I heard Andy Galpin talk about this, that those athletes that have no problem, they're just bouncing off the walls when they're getting to the gym. He'll oftentimes say, you're not even going to listen to music when you're training, because that's going to even turn it on a little bit more. And then another thing that he talks about that I've implemented in my training, I try to do for most part, although I skipped it today, is just after the workout ends, just spend 3 to 5 minutes just down regulating, a couple of deep breaths in and out, and just to turn that down as you spoke about.
I've heard that from him too. And I got to be honest, I don't see a huge value in that because you're going to get a natural recovery anyway. And just what you do in those first 3 to 5 minutes versus what you do the rest of the day is a drop in the bucket. I would actually say that time down regulating is probably more important around other activities and through other parts of the day rather than just around your workout. I'll be honest, there's not a single study that would support that at this point. Recommendation wise, hey, if nothing else, it gets you to pay more attention to what you're doing. But in terms of it magically leading to greater strength gains or anything like that, unfortunately, there's a lot of advice out there where, and it's just the same stuff with don't have caffeine first thing in the morning because it's so bad for you and it'll increase cortisol. And we've debunked the crap out of that. It's just a poor understanding of mechanisms at that point. Think that if nothing else, it just gets somebody to pay attention to what they're doing. But I would argue that you're equally as well served by what you eat in that first, say, 3 to 5 to 30 minutes after your workout and stuff like that. So there are ways to do it, but I guarantee what it has done for you on the days you do that is it simply helps you get control back. And then it's easier to apply that to other areas, because I would argue where it could be really useful is prior to going to sleep. In order to get you into that phase. Post-workout, you're getting natural recovery from the catecholamines anyway. I've heard that they'll use it to try to clear lactate. Dude, lactate clears so fast when you're done working out. Like if you're not continuing to engage in high intensity, it's a pretty low-hanging fruit from the standpoint of things
that one I haven't
change.
heard, so that's new to me.
Yeah. And so I've heard that. But again, this is where people take an idea and then they twist the crap out of it because they're like,
I wonder,
ooh, it helps with downregulation. And no, that means lactate clears faster. It's like, it's probably already done.
did the lactate thing, so you're familiar with the Wim Hof?
Yeah.
Do you think that came from that? Because he's an interesting guy, and I know he's had studies where they've literally injected himself with, I don't know what bacteria specifically, and so did any of that come from there at all?
Who knows? I don't know, man. Honestly, anymore on social media, I don't know where half the shit comes from. What was the genesis? It's always it'll come from some grain of truth or something that somebody saw work one time, and all of a sudden it becomes gospel. And I don't know. It's funny for me because, look, don't get me wrong. The one thing I will readily admit to, having been in this field long enough and having been a strength coach myself and stuff like that, is there's certain things that we've done in the weight room, that we've done on the field, that sort of the coaches, the strength coaches, people like that, they had it figured out before the scientists did. Then we'll do the science and go, oh, hey, actually that works. But there's been other things too that over the years we've changed our minds on because no, that actually doesn't work. It may actually be counterproductive. And so sometimes the science is ahead of the practice, sometimes the practice is ahead of the science, and what's beautiful is when the two match up. And I think that, and I try to keep that in mind, And that's why I said, even looking at that down regulation post-workout, there's really no science to suggest that's that important compared to other things you do. But it sounds great and appealing. Like somehow it's like you got to now bring the system down. But to be honest, if you're still bouncing off the walls at the end of your workout, I'm not sure what you're doing. I've even heard, don't look at your phone when you're done, because then that'll just amp you back up. It's like, yeah, but you might be more anxious if you actually were expecting some calls, or you're on the clock and you got to answer some stuff. It's get back to your life. So I think there's an individual factor there that becomes very important. I think what's useful about that recommendation is it means you are continuing to set aside and take time for yourself. So there's that level of sort of commitment and engagement that I think is really important. And there's many ways to do that though, right? So there's not just this one way. And if that works for you and you feel like that allows you to finish off that workout and feel good about now carrying on with the rest of it, I think that can be super useful. It may also depend on when you do it, right? Whether you're a morning workout person, an afternoon or evening workout person, things like that. Because like I tend to work out later in the evenings, and at the end of the day, I can tell you that 3 to 5 minutes post-workout isn't going to do nearly as much for me as what I do from then on to try to allow the system to recover prior to going to bed. Drop in the bucket.
Yeah, I think the context-free advice thing is really interesting, and contextualizing advice takes a lot of time, and people don't end up doing that. I remember with the whole morning routine people thing, I'll share with you, again, very simple, dominant, but I find when I get up, like for me, those first 2 hours, if I get up at 5:30, 2-3 hours, it's the most peaceful time for me.
Yeah.
And sometimes I like to just sit out there and drink my coffee within 30 minutes of getting up, because that's what I like.
There you go. You're good.
But I recently heard Tim Ferriss talk about this, and he was saying how he doesn't have a family. He was saying something the same tune, that he likes to get up, do some deep work, but he doesn't know what it's like when you have a kid jumping on your solar plexus at 5:30 in the morning.
Correct.
It's a little hard to do your morning routine when your 3-year-old's doing that. I love her, best thing ever, but I don't think she has an appreciation that I need to do deep work at 5:30 or 6 in the morning. You know what I mean? And so I think that's really important for people to understand, that you're not losing out on something if you're not exactly doing it how the 24-year-old fitness coach is telling you, or performance coach is telling you. As intelligent as they might be and as good as the advice might be, it just might be bad advice for you, specifically in your context.
Yeah, I really like these 24 and 25-year-old life fitness gurus and life coaches. To your point, just wait. Like I tell a lot of my students, I'm like, you don't know what it's like to be 50. I know what it's like to be 25. Right? So it's like, there's a context to this that you could build on. But you're right. I think sometimes, and I'll freely admit this even from an academic standpoint as well, and we try to come up with these solutions, we work with these athletes, is I think the thing that I have really learned to appreciate over the years, maybe more so than when I was younger and earlier in my career, is meeting them where they're at. So to your point, yeah, you can come up with this, I get up. What should you do in the morning? Here's your 2-hour routine, and do yoga, do deep breathing, go for a walk with no shorts on, blah, blah, blah. It's like all these things. And you're like, bro, it's not realistic. What are you going to do? And so it might work for some people, but the reality is, like you said, when you have kids or you have other responsibilities, things like that, I think what's cool is then you figuring out in that context what then does work for you. So for example, I love to get up in the morning and take our dog for a walk. That's my time with her. It's sun exposure. So you're starting the day off with this light exposure. I love it. I feel good. We're just getting moving. It's not exactly like it's a high intensity type thing. Sometimes it is, depending on what she sees, and then she'll start hauling ass. So we're good. But it's little stuff like that. So again, you build into your routine what gets you going in that space. And like you said, with the kids, yeah, there might be period of time where I would love to be able to do this, but here's what I've really got to work with. And so it's figuring out what that looks like and paying attention to how it makes you feel. And maybe some days are more ideal than others, right? In terms of how you can balance that. But to me, it's also about the entirety of your day. So it's not just that first hour or two. It's not even just the last hour or two. It's how you manage things over that period of time. So when we talk about what can influence the endocrine response and what can the endocrine response influence, right? And we look at this as a dual direction type of relationship. How you do all of these things has a fundamental impact on the system, right? And how that system balances, how that system adapts, recovers, overreaches. And I think it's paying attention to that completely. Also paying attention to preferences, paying attention. It's funny. You could put an ideal diet together for an athlete, and everybody thinks, oh my God, working with high level athletes must be so amazing. They're so motivated and they'll do whatever. Oh my God, if you only knew. No, honestly, some of them are the worst because like they've gotten by on talent to a great degree and they're so damn genetically gifted that they're like, nah, what I'm doing works. And so sometimes it's just finding the little things to adjust with them that make them that few percentage points better. Then they start to buy into other things when they see the value of that. So and I think the other thing that people make a huge mistake doing is trying to fix everything all at the same time, right? Find the low hanging fruit, find the big rocks, right? What are the things you can put in there first that will make the biggest difference? Then you can work on the smaller stuff. But if you try to do it all at one time, and we've done this, I think one of the reasons we've had pretty good success working with the athletes and the teams that we have over my career is we don't go in and just implement everything in year one. We find the 2 or 3 biggest things where we can make a difference that makes sense for what that program's goals are for the athletes they have. And then over a period of time, once we get really good at those things, think about, do we need anything else? Maybe not. And if we do, how do we layer it in? Because the one thing that will often happen, and I would imagine you've got to run into this from a medical standpoint, but if you give somebody too many things to attend to, they wind up doing none of them. So it's not even, okay, they still did 2 or 3 out of the 6, so that's good. It's like, no, sometimes you get that straw that broke the camel's back. We're like, okay, I'm good with that. I'm good with that. I'm good with that. That's one too many. I'm not doing any of it now. And honestly, we run into this with athletes all the time. It's actually, once you understand that, it gets a little bit easier to gauge how you approach this.
Yeah, I forget. It might have been The Power of Now in that book where they had talked about, I think when somebody tries to do one habit, the likelihood that over 2 weeks might be very high, 80 to 90%, somewhere in that. You add on to 2, all of a sudden drops down to like in the 60s, whatever. You add on 3 habits or 4 habits, it's basically going to be in like the single digits attempts or whether they're going to be able to execute that. And so, yeah, what you're talking about, behavior change, very complex. So yeah, I think giving people actionable, small things that they can bite on. And also it's empowering when you become successful with something like, oh, okay, I got this. You actually got this. And I think that's a really good strategy. I made note of 2 things that I really wanted to get a deeper understanding on. You earlier talked about with respect to trying to promote parasympathetic dominance. You said endurance training does tend to help with that.
It does.
Are we talking more low intensity, steady state cardio, or are we talking about more like long duration and it can be high intensity, or does it not matter?
It doesn't matter a whole lot. They both work. I think one of the mistakes we've made in how we promote this sometimes, and I will say this, let's lump resistance training in here too, is I don't know why, but we started to try to treat it as what's best and treating it like an either or. And the reality is it's all good, right? So if you could only resistance train or do aerobic exercise, what should you do? And people are like, oh, and resistance training, right? Because you build muscle, you can still build some degree of aerobic fitness with that. It's so good for you. And then other people are like, no, endurance training because of the cardiovascular benefits. And I'm over here going, or both. Like, why does it have to be one or the other? So we play this really weird semantic game that doesn't really need to be played. So I would even say from an endurance standpoint, we know there are tremendous benefits to high intensity interval training. Guess what? There's also some pretty damn good benefits to long duration, moderate intensity training. And if you try to do high intensity every day, that's going to be that is really sympathetically taxing as well. So my answer to that is mix it up. And there was just a study that came out where they were looking at the training habits and training approaches of most of the elite coaches for endurance athletes. Most of those athletes spend very little of their week at their highest intensities. There are a lot of what we call zone 2 and zone 3 type of training. It's not always hard, right? So I think there's a value in that and mixing it up. And part of it also depends on how you feel. Because here's the thing is, don't forget about the value of psychological responses to this too. And we know that honestly, from a depression and anxiety standpoint, from an aerobic standpoint, the strongest effects still appear to be with low to moderate intensity exercise. It doesn't mean high intensity can't be useful for other factors, but we don't just want to stress that. So again, I think getting away from the either or, better, worse, things like that, is the reality is they both work really well.
Yeah, I think maybe I have some sense of why. I think we really get excited and get married to the idea about being efficient. Efficiency is really easy. I'm honestly more interested in effectiveness. I think that's probably far more important in terms of quality of life and quality of the results. And I think that's what it is. Okay, if you have 3 hours, how can I maximize that? Again, we talk about Tim Ferriss, love him, but the 4-hour work week, I think it was, or the 4-hour body and the 4-hour chef, all those were such hits because, okay, how can I be most productive in the least amount of time? How can I hack the system, so to speak, or how can I hack my biology? I think that's where that comes from. And I don't really know if we can hack biologies.
And I think it depends if we look at it from an ROI standpoint. The question you have to ask, and this is going to be a little different for different people, is the investment time or is the investment effort?
Mm-mm.
Because for some people, if you're not a big exerciser, like you don't love exercise, the intensity part can be very daunting. Shit, this sucks. This is hard. I don't want to do this. Versus, I'd rather work out for a little bit longer, but do it. You know what? That's cool because that still works. But if you look at it from a time investment, it's actually cool. One of my doctoral students for part of her dissertation is finishing up this study now, and she actually just presented on the preliminary results. But we're comparing traditional resistance training to concurrent training. And so same lifting program plus doing high intensity intervals at the end, and then compared to high intensity functional training. So more of like your Metcon CrossFit type of approach. And it's interesting because actually the concurrent training group is coming out ahead on most measures. When you talk about efficacy, right? The effectiveness. But once you adjust for time, they're actually remarkably similar, and that high intensity functional starts to win out on a lot of things, right? Because it's a shorter time. So now what we're doing is we've come up with a calculation where we're looking at it as percent gain per amount of time. So how much lean mass did you gain per hour of training that you did, right? So what's that return on investment from that standpoint? And I think that gets left out. And I think that's even been the case with a lot of the stuff on resistance training and like high load versus low load. And they go, oh, both work. Like both, whether you're doing 30 reps to near failure or you're doing like 10 reps, whatever, it's like they both create hypertrophy. Yeah, strength is a little better with the 10 reps, but you still get stronger with the 30 reps. But my question is, okay, now adjust for time on that. Because to do 30 reps takes 3 times as long as to do 10 reps. So so if it's just as good, but it takes you 2 to 3 times longer to do, is it really as good? It depends on your preferences there.
The one thing with if you're doing, I guess if you're doing near failure, you'd still be waiting longer between sets. But I think from a recovery standpoint, even if you are going near failure, I would think that you might be ready to go within 60 to 90 seconds, maybe. Whereas opposed to a 10 rep or 8 rep, like at 80% with one RIR, you might need 3 minutes to recover.
For optimal strength, for if you're looking at strength from set to set, but we've done studies where we do 60 to 90 second recovery. And so those training sessions can still be pretty short depending on how you structure it, let alone, hey, now let's look at, say, supersets. Right. What happens when you're doing push-pull, things like that. So my point in that is that sometimes we hear it's as good as this or it's better than this, but you've got to put it in the context of what the other considerations are with that from a time, from an effort, things like that, from an equipment standpoint. All of these things need to factor in. So I think what's cool, here's what I take away from it. There is a menu of options to improve your fitness and improve your health. It really depends on which one will fit for you that you will stick with, because as we already mentioned much earlier in this whole thing, consistency is key, right? Like that will win out over almost everything else. And so the consistency aspect is so critical, but the reality is you have a few different ways to get there, all of which work. Some may work a little better than others. Now, if I'm working with an athlete and we're trying to set a world record, we're trying to win Olympic gold, we're trying to do these things, we're going to look for the best option. Even if that option is 1% better, that can be the difference in placing. For most people looking to improve their fitness or their health, man, you got a couple ways to get there. Yeah. And so there's no one right way. And that's where, even when we talk about the hormones and the endocrine aspects behind, this is where monitoring becomes very useful, because it allows you to gauge how these things are working for you in a much more holistic sense. So not just did my bench press go up, not just is my blood pressure down, but it's like, how am I physiologically doing? How are my blood lipids? How's my nutrient status? Am I taking in the right micronutrients to further support this? So then you can fine tune it a little bit and do it in a way that fits what you have at your disposal, what you can get at your disposal, and what you prefer too. And I think that can go a long way towards really improving health globally.
Love that. One more thing I want to put a bow on, Shawn, before I get your take on muscle preservation and GLP is IGF-1. We talked a little bit about growth hormone, downstream IGF-1, maybe even IGF-2. Help me think through this, how I might use this in a clinical practice. So of course I'm really interested in thinking about injury and recovery. And I've been thinking a lot about, is there a role of me looking at this in people who are just taking longer with respect to their recovery after an injury, right? Whether it is a treatment intervention that I've done or not, is there a role in that? And how would you think about that?
So I think it's important to realize, so IGF-1 really comes from two sources, right? So the primary growth hormone-driven IGF-1, the one that's the downstream from GH, is going to be liver-derived IGF-1. However, muscle and other tissues, but prolifically muscle, but certainly even adipose tissue and bone can do this. There's also localized IGF-1 production and secretion as almost more of a paracrine or autocrine gland versus an endocrine gland. All right. So muscle can function in its own capacity. So when you measure that IGF-1 is also going to be dictated or be influenced by which of those things you're looking at, right? So the liver-derived IGF-1 typically has a fairly significant lag from the GH stimulation, right? And can be anywhere from 12 to 36 hours in some cases. Whereas if we see an immediate rise in IGF-1, that's typically more on the paracrine side where we're getting it from the muscle itself because of contraction and the production at a more local level. And that can be a very important influencer on muscle growth and repair and things like that as well. So I would say if nothing else with IGF-1, we typically do include this as a measurement in most of the biomarker work that we do if we're looking at growth hormone as well. I think what is useful to know though too is if you see and you're tracking IGF-1 responses is also being aware of what can influence IGF-1, because if you're also getting markers of inflammation at the same time, so inflammation can suppress IGF-1 secretion as well. So looking at these in concert can be very useful to start to figure out what the cause of this might be and where you can intervene a little bit more effectively. But we've found IGF-1 to be a fairly useful marker. And what was interesting for us is we've got a couple studies where we actually showed that changes in IGF-1 over a sports season were actually tied to performance, right? So we do know that it does appear to play a role here in terms of adaptation to some of the things we see. So I think IGF-1 can be fairly reflective of stress, overall stress to the system, not just distress, but the stress of training, the stress of life. And so I think that IGF-1 can be important there. But again, time course is going to dictate a lot of stuff in terms of how, in what proximity to training or competition were the draws taken. And that's going to tell you whether it's primary, because honestly, on most of the panels you can get, it's not going to be able to distinguish between paracrine derived or endocrine derived IGF-1.
In those studies over lower IGF-1 as in worse performance is what I'm guessing?
Yeah,
okay.
Correct.
Gotcha.
Yeah, especially around strength and power.
Okay, cool. All right, let's talk about GLP-1 agonists briefly.
Sure.
With respect to muscle preservation. So I think I've been a record of saying this. I think, and at least in my time and practicing medicine over the last 20 years, maybe I would say these have been one of the most revolutionary medications, although we're now learning that the effects are not as profound as they are in the clinical studies and real world results. But I'll table that for a different day. But I think the effect that they've had in terms of just the obesity crisis have been very good. The huge downside that I've recognized in my practice, I use these, I've seen it a lot. I think it's well recognized is their negative effect on lean body mass and fat-free mass. And so I just want to get your general thoughts about that. And then I'll get into what Dr. Mike calls non-adrenergic performance enhancing drugs.
Yeah, I think that when we look at it from that standpoint, you look, so with these anti-obesity medications, if we're looking at the GLP-1s and variations on that as well, I agree with you about the revolutionary nature of them, right? And what they bring to the table and how they've modified this. We do see pretty significant lean mass loss, but what's interesting is you also sometimes see that with just caloric restriction too, right? So it's not as unique to them as one might think. What was really cool, if you delve into the science behind this though, where it appears that these GLP-1s do not exacerbate lean mass loss is in those with type 2 diabetes. So there's been some really cool studies, especially early ones. And remember, these drugs were designed for type 2 diabetes treatment. So there's something that appears to work within this context where they don't get the same degree of muscle loss. And I have a feeling it has to do with the insulin regulation and what it's doing in that population that may be more needed than what you would get in just an otherwise overweight or obese individual with obesity compared to somebody that's actually got true metabolic disorder in this case. So I think that's pretty interesting. But the reality is, I think there's some ongoing trials right now looking at what some useful interventions might be. We could take a very pragmatic approach to this and simply say, okay, what are two things we know helps with lean mass? Protein and resistance training, right? So if we use these as a foundation, I think one of the things that I find interesting, I'm actually part of a review paper on this where we had looked at the role that these could play that we published last year. It's funny because there's people designing like GLP-1 workouts, AOM, anti-obesity medication workouts. And all they are is essentially resistance training for beginners, just with a new label, right? So they're like, oh, take a little longer rest because they may not have as much nutrient availability. So it's going to be a little harder, and we'll progress them through the weight they use. And you're like, so yeah, beginning weight training program. Got it. So there's not much difference there. I think the thing to pay attention to is if somebody's losing that degree of weight, paying attention to fatigue factors, and also being aware of micronutrient deficiencies that may be going on, because that might help support some of what we see as well in terms of adaptation in a good way. But I think the reality of the situation is, look, at the end of the day, there's not much of a downside to resistance training, right? So we know and I agree with you. I think one of the concerning parts is that lean mass loss, because muscle is our bank, right? That's our health bank. That's our health currency in order to preserve function. So we don't want to lose a lot. But at the end of the day, man, anytime you lose significant amounts of weight, you're going to lose lean mass along with it. The question is how much. And I think in some of the studies, they've seen lean mass losses anywhere between about 20 and 40% of the total weight lost. And I think with some of the caloric restriction studies, it might be more 16 to 20 or 25%. So they overlap in that range. It just seems to be a bit more pronounced with the medications. But I think what we have not really gotten deep enough into yet is the things that can be done. To your point, even though the amount of weight loss doesn't seem to look quite as promising. It's still good, but it's not quite as promising in real world as what we're seeing in these clinical trials when you're not supervising everything that they do. A damn thing called choice to get in the way.
Yeah, and cost, right?
Yeah, absolutely. Yeah, it's that adherence factor that goes a long way with it. And that's where I think that what I see as an opportunity from a dietary standpoint was sort of protein intake and educating on that. And then from a resistance training standpoint and the value of that for lean mass is the educational and lifestyle change aspect that goes with this. So if somebody cannot or will not continue on the AOMs, how are they managing themselves when they come off of it? And what do they do long-term? And do we have an opportunity here to teach some more positive behaviors?
Have you worked with athletes who are on these?
No.
Yeah, I'm wondering, would you counsel somebody, so that floor 1.6 to 2.2 grams per kilogram, the ISSN recommended, would you tell somebody to be on the higher end of that, 2 to 2 point at that point?
Yeah. And I think if you look at some of the work that Joey Antonio and others have done in that space, especially with caloric restriction, which is going to be a hallmark of these, right? Like, how does the weight loss occur? They're not eating as much, right? So there's a huge aspect of that in terms of what it does to appetite and otherwise. But I think that we've seen that during situations of severe caloric restriction in particular, higher gram per kilogram doses of protein does seem to do a better job of preserving lean mass and facilitating some degree of adipose loss too.
Yeah. The one caveat I think I'll give to people is, again, because this is my world, I think I can be the person who is fighting tooth and nail to guard and hold on, because that's the currency, right? The currency of longevity we talk about is muscle.
Yeah.
Being in that catabolic state and nutrient deficient state you talked about, your injury risk goes up high.
Absolutely.
So now if you all of a sudden are really pushing and you're just going failure all the time, and maybe you're adding extra resistance training sessions because you want to hold on to that muscle, you have to be really cautious. So you have to be really responsible with how you program around that as well in order to understand that, again, stress is stress. And
amazing point. Yep. And I think that's where we have to be smart, especially if a lot of these people that go on the drugs because of their weight loss efforts haven't worked and things like that. But part of what the challenge has been for them is a lack of ability to adhere to exercise programs. And maybe they've never really weight trained before. Then you start them off as a beginner anyway, right? So be cautious in how we progress, paying attention to strength gains, paying attention to your point about recovery and injury risk and things like that, and being aware of that, but also paying attention as they lose more weight. How do some of these things change for them and how do they continue? So I think there's some adaptation that goes on there, but you're exactly right. I love that you said that, because I think that's an important consideration is we don't want to just do more, because to be honest, in a state of reduced nutrient intake, recovery is going to be mitigated to some degree anyway. And so we don't want, I'm not saying go lift weights 6 or 7 days a week. Honestly, get a good 3 days in, get your recovery, do your aerobic exercise because it's good for you and it's going to help with everything else too. And it's really just a fundamentally structured exercise program that we're going to try to base around their feelings of fatigue or whatever else is going on. But I think that with some of the patients that report feelings of fatigue and stuff on this, it's a catch-22, isn't it? It's like they may not feel like they have the energy to work out because of it, but yet the funny thing is we've got plenty of studies that show that working out will help with overall sort of feelings of energetic arousal and capability so that they feel like they can do more. So some of it is just, what will you do? What will get you going? And then how do we help you get there?
Love it. So where there are problems, there are opportunities. And right now, the race amongst the pharmaceutical industry is to try to combat this big problem that we've highlighted and everybody's highlighted.
Yeah.
And so one of the common things that they're doing is including these myostatin inhibitors, which have been studied in other pathologies, right? So in illnesses such as spinal muscular atrophy, those kinds of things. And maybe starting off with telling people what myostatin is and myostatin inhibitors are, because a lot of these agents are combining those with either the semaglutide or it's going to be tirzepatide and that's going to coming up. What can you tell us about that?
So think of myostatin almost working in opposition to growth hormone is the way I try to phrase it. So myostatin it's your governor on muscle growth, for lack of a better way of putting it, right? And so if you can inhibit myostatin, you take the brakes off muscle growth to a great degree, right? And so if anybody ever wants to see the difference in this, actually look up myostatic inhibitor cow. And there's a certain
dogs, and they got it all.
There's certain species of some of these animals that are born without the myostatin molecule, and they're huge, they're jacked, traps to their ears. But anyway, what we're looking at though is, and this is funny if you think about it. So you're like, hey, we've got a drug that'll help you lose weight. Oh, but you might lose muscle because of it. So not to worry though. We've got another drug that you can take with that to help you from doing that. And you're just like, oh.
Yeah, you're selling the problem and the solution at the same time.
Yes, and it's freaking brilliant. And so you're like, all right, here you go. But I think there was a study with semaglutide and bimagrumab. It was an activin A signal inhibitor.
The Regeneron Pharmaceuticals one you're talking about.
Yeah, the ACTR2. But it was cool. But most of those studies at that point had been done in mice. But it was interesting because combining those two in obese mice actually had a 10% increase in lean mass. So this is interesting. So I think last I heard, I believe there's a couple trials in phase 2 that are looking at this now. I'm really curious to see what happens in phase 3 in terms of the long-term effects of this. But look, I got to be honest, like in the athletics world, especially bodybuilding, myostatin inhibitors have been the holy grail, right? It's like, because there's been plenty of like supplements marketed as myostatin inhibitors, none of which actually work, but it's the holy grail from a muscle growth standpoint.
I wonder if we're talking about the same one, because the one from Pharmaceuticals is actually I think that one was in primates, in monkeys, which is why I'll link a video.
Wait, the one I'm aware of is in mice, and I think that was published in 2024.
Okay. There's a really good video from Mike Israel. I love that guy. He's so funny. And I'll link that in the show notes for people where he goes through the different forearms about this. But then recently, Eli Lilly has this Believe trial where they also showed very similar effects. And of course, they combined it with, I think that one was semaglutide. So there's going to be with tirzepatide, and they're going to go head to head. So I'm really excited and interested in looking at this. But yeah, this is why that Dr. Mike, I think he's very bullish on this. He calls them non-androgenic anabolic drugs.
Correct. Absolutely.
I'm not going to lie to you. But actually looking at it, it's like, can I invest in this? Because this is where we're going to go, like you pointed about, in the Holy Grail. And even if it's not FDA approved for several years from now, I could see it being on the black market and gray market and stuff.
Matter of time. And it's funny because every time I see something, you asked if we worked with any athletes that are on like GLP-1s or anything like that. My honest answer is no. And I should have said no that I'm aware of.
Right.
Because some of them, it depends on what they're doing. But we may see this in some of the weight category sports, but we also have seen that in most of these, if you have an athlete that's not significantly overweight in the first, or anybody that's not significantly overweight, the effects of these GLP-1s is going to be fairly modest from what you get. And I hope I don't have any athletes doing this because of what my concern is over the loss of muscle, which they really need for performance. I think where I wouldn't be surprised if you don't start to see this is like retiring NFL players that were linemen, right? When they decide it's time to go back to normal size, like how do I more quickly do this? I think that's going to be a whole nother argument there in terms of what we might see.
That makes me wonder, has WADA or IOC, any of them have taken a stance on this in terms of weight cutting sports? Is there any, because this could be a really slippery slope in terms of what you can and cannot regulate if it's a medical issue.
But here's the thing, if it's a medical issue, they can get a therapeutic use exemption.
Right.
And that's true with testosterone, with growth hormone, with kids, all kinds of stuff. So it depends on the TEU. But in terms of, I have not seen it specifically. Now, I haven't looked recently, but I have not seen it specifically on banned lists. But my guess is it's probably a matter of time before they at least list it as a substance of concern and start to consider whether or not it should be regulated at all. More often than not, unless they can tie it to performance enhancement as a performance enhancing drug, there may not be a reason to, because it's not a stimulant. There's no evidence that it helps with performance. But you're right, in terms of weight cutting sports, it would not surprise me if we don't start seeing that show up if we haven't already, and just depending on the way it's been handled from that standpoint. But again, in most of these populations, even when I'm thinking weight cutting sports, other than say, and it would be interesting because it'd be so ironic in bodybuilding, because we don't know right now. We can suppose, we can theorize that resistance training and protein intake should help mitigate lean mass loss. It doesn't mean it will reduce it completely, like it'll eliminate it, right? We don't know. And so if you have a physique competitor who really needs to maintain muscle, but yet wants to cut weight, GLP-1s might be a really dumb way to do this, especially if it's going to cost you all that muscle you've been working for. We also don't know how they might interact with other drugs they might be on. If you're looking at it from an athlete standpoint, let's say a fighter, so you're doing MMA, you're talking boxing, things like that. Again, for them to make weight in most cases, it's not so much the fat loss that matters, it's your ability to drop water. And how do you become more efficient at being able to drop water, have more muscle? Because all I need to do is dehydrate that muscle, I can make weight, put it all back on. We want to get rid of the fat though. So if they're eliminating these things, it would actually potentially be very counterproductive, which is probably why I haven't seen much of it in that space yet, at least being talked about. I have no doubt there's somebody doing it, because that's what athletes are going to do. There might be a way they get an advantage to it. They'll give it a shot, but I haven't seen it broadly at this point. It'd be interesting to see how it plays out in terms of what we see with that. I mean, if you want to talk about myostatin inhibitors, that's going to be a different story.
Yeah.
That one I can see very quickly winding up on a WADA list once they perfect this.
Exciting stuff. I'm keeping a close eye on this one. And we definitely got to get somebody here to dive a little bit deeper into the mechanisms and visit this, because I think this is very exciting. Shawn, thank you so much, man, for coming back. This has been a whirlwind of a 2-part series for people in terms of performance enhancing endocrinology, if we can even call it that. Any parting words for our audience? I think one thing I'll say is, even just in the last, 4.5, 5 years, the first time you came on and now, I am excited about the fact that more people are paying attention to performance. Yep. As much as we've been bashing on social media, I think the one thing it's done is people are paying attention to the fact that, hey, I'm not just interested in not being sick, I'm interested in being healthy. And that's like a motto of mine, is that health is not the absence of a disease. And I know you ascribe to that philosophy. Absolutely. Anything you want to leave the audience with that?
I think at the end of the day, if you approach it from the standpoint that we're all athletes, right? We were designed to move. And so when we look at it from that standpoint, you may not be an elite athlete. You may be happy to be able to do certain things, but I think the reality is, and the older I've gotten, the more I appreciate this, is the ability to maintain function for as long as possible to do the things you love. And I think the reality is we've already talked about ROI. I think we need to think about that investment now for what the return is later, in terms of your ability to carry this out, to be able to continue to exist in a state of health and optimization. Because I think it's a great point. And even it's funny, because I think one of the things that drove me in this space around biomarkers and things like that, if you actually look at the classic definition of biomarker, health and performance are not really mentioned in that. It's all about absence of disease or seeing how drugs are working. And so to me, when we start thinking about health, performance optimization, health optimization, psychological effects, things like that, and mental health, I think all these things start to go together. And so I really would encourage people, Google will give you some information. I actually like the format that you do for this, because I appreciate that over the years. And I've said this before on your podcast, but it's awesome for me to see a former student doing the things you're doing. Like that, to me, that's a win, right? I'm so proud of you and what you're doing to get this information out there and what you do in your day-to-day and your practice and things like that. But I think for me, being able to carry that message out and trying to get people to simply pay more attention to what they're doing. And I think that, I think probably one of the truest things that has held over the last 20 something years of my career is that if something sounds too good to be true, it probably is. And so that's my caveat with social media, is it sucks, because I got to be honest, there's some really useful information out there, but unfortunately sometimes it either gets twisted and it goes from science to science-y, or it gets bastardized, or people just go off on a rail. And I think that there's this human nature of we kind of look for the things that reinforce our beliefs in many cases. Oh, I knew that's what I needed to do. And I think too, like looking for the specific, but honestly, at the end of the day, consistency of training, balancing your diet. You don't have to be overly restrictive, Just use some common sense guidelines. Start with protein, fill in around it. Don't forget about your micronutrients and sleep. Man, if you start with those three things, you're going to be so much farther along than most people. And I think as we hit on today, there is no one right workout program. There's multiple ways to get there. Do what will work for you, but there's enough science behind each of these approaches to do it well, but you've got alternatives. There's some variety in this that you can pick from, but the basics still hold true. Lift some heavy stuff, do some aerobic work, lift some, sleep. Don't eat like an idiot. I know people don't like simple, right? They want complicated. They're like, how can I make my daily routine the most efficient? And they do it in a way that is the least efficient thing I've ever done, that I've ever seen. So I think that just simply paying attention to the fundamentals, it's not sexy, I get it, but it works.
And that, folks, is putting the health back in healthcare. So, Shawn, thank you so much. Always,
you bet,
man. Looking forward to the next one.
Absolutely. Take care, brother.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, Aretha Yepori on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.